اهلا وسهلا. اول شيء اعتذر عن عدم الحضور personally, بس I did not want to miss the chance to debate Dr. Faisal. I will take it against me. This is the only point I think you should take against me regarding this debate, but I think it's going to be an easy debate to win. So, Dr. Faisal presented a number of very good points. However, I'm going to show you a few things that will make you actually change your mind and say this patient should go really for a VAD or advanced heart failure therapies. So in the beginning, just a disclosure, we're not comparing patients who are not a candidate for advanced heart failure therapies to those who are. So this is not a debate about if a patient is not a candidate. If they're not a candidate for advanced heart failure therapies, either a VAD or a transplant, then a TEER should be the way to go for sure. However, we know, like all the literature, all the data, and all the studies that have been shown that patients with heart failure, they usually progress. So usually when they have their first events or second events, like the patient Dr. Emil presented, eventually they will progress to advanced heart failures, and eventually we need to do some sort of intervention. Otherwise, they will be in trouble and their mortality is really high. I always ask myself three questions. Why do we treat patients? So if you ask any patients, why do you want to be treated? They tell you, I want three things. I want to live longer. I want to have a better quality of life. I don't want to go to the hospital, and I want to enjoy my life with my family. So let's look at these two options with regards to survival. There's no comparison between survival between patients who are referred for advanced heart failure therapies versus those who are referred for TEER. So Dr. Faisal presented this slide, and I agree with him. Transplant is fantastic. So if you look at the 5-year survival post-heart transplantation, I think in the newer data, it's around 80% or more. So that's very good. But he showed, and I totally agree with him, that you don't have enough donors. So I'm going to not focus on transplant because transplant is way superior. We know that. So I'm not going to focus on it. And I'm going to focus on something that we have available on the shelf, which is MCS. So Dr. Faisal showed you some survival with the TEER and with the clips. And I agree with him. The TEER is effective therapy. However, look at the survival for patients who are getting assist devices. So the best trial that was conducted in the literature about the newer generation VADs are the Momentum 3 trial. So the Momentum 3 trial compared patients who have advanced heart failure to with HeartMate 3 compared to HeartMate 2. And if you look at the overall survival, you look at the 5-year survival of around 60%. So by 5 years, 60% of our patients who got a VAD were well and alive. And if you look at the real-world data, like the real-world data for patients who are implanted with VADs, these are not clinical trial patients, just from the SDS data registry. If you look at the 1-year survival for patients who receive LVAD, when we're talking basically now about the HeartMate 3, it's around 86%. And if you look at the 5-year survival, it's around 65%. So it's better even than the Momentum 3 trials. However, the younger age, if you look at the younger age group, like the patient who Amal presented, the 5-year survival was around 76%. So that's almost approaching the transplant point of view. What about patients who are older than 70? I'm not going to highlight it. They're not as good as in survival. They reach up to around 53%, which is still better than TEER. Now, let's look at the TEER data. Dr. Faisal presented the QUAD trial, and the QUAD trial is probably the most well-done study. And although there is a significant reduction in mortality with the TEER device, however, if you look at the 5-year outcomes, 60% of the patients who receive TEER are dead. So that's really not good. And we know that, I just showed you that patients who got VADs were actually had more likelihood to survive compared to those who received TEER. Now, one that we have to make clear is what happened when you deviate from the co-op trial. We know that the co-op trial was very strict. However, nowadays, majority of the patients, or I think a big portion of the patients, they're not getting the full co-op criteria. And this is the co-op criteria. As everybody knows, that the co-op criteria state that you should have an ejection fraction above 20, your LV in the systolic diameter below 70. You should have some pulmonary hypertension, but not greater than 70. And you have to have absence of severe RV dysfunction and a severe TR and hemodynamic instability. Now, there's a beautiful paper that looked at long-term outcomes for patients who undergone TEER. And if you look here, freedom from death in the left side, you can see for patients who had not the co-op criteria, their 5-year survival is 25% only. So 75% were dead by then. Now, the question, I think Dr. Faisal mentioned that patients who got TEER are probably sick, and he mentioned that maybe because these patients are sick, they're benefiting from this. However, one might ask, did the VAD patients are sick also? Are they sicker than those who received TEER? So let's look at the inclusion criteria for the big trials for TEER and the ones in the Momentum 3, which is for the HeartMate 3. If you look at the inclusion criteria, HeartMate 3 included patients who are more sicker. So they are more NYHA functional class 3 and 4 compared to some 2 in the co-op trial. They needed to be iron probe dependent, or they needed to be having advanced heart failure symptoms. The majority of the patients had lower ejection fraction. And if you compare the populations in the Momentum 3 versus the co-op trial, for example, you can see that majority of the patients are actually NYHA 4, so 99% compared to only 6% in the co-op trial. Their ejection fractions were lower, so 17%. A big number of them were inotropes, and their GFR was around the same. Now, okay, so survival, it's clear cut. There's a superior survival for advanced heart failure therapies compared to TEER. However, let's look at what about quality of life. Some people say, you know what, maybe TEER will provide better quality of life because there's no something sticking out of the patient's abdomen, etc. Now, if you look at the LVAD, there's a beautiful study and a beautiful analysis from the Momentum 3, which showed that in overall cancer sensitivity questionnaire, there was a significant improvement compared to baseline from baseline and in comparison to the HeartMate 3. And also the 6-minute walk test improved significantly with the assist device compared to medical therapy or baseline condition. What about TEER? It also showed there's significant improvement in the cancer sensitivity questionnaire. However, not so much with the 6-minute walk test. Now, if we go and compare the if you look at the co-op Momentum 3, there's more significant cancer sensitivity questionnaire with the Momentum 3 compared to the co-op trial, and there's more significant improvement in the 6-minute walk test in the Momentum 3 compared to the co-op trial. So this overall shows that patients who advanced heart failure therapies were more likely to have a better quality of life and more likely to have a better functional capacity. It's also very, very important to know who did the co-op trial exclude. So the co-op trial actually excluded patients who are having advanced heart failure therapies. Who have advanced heart failure or stage B heart failure. And this is similar to the patient that Dr. Amal presented. So if you look here, we know that stage B is defined as heart failure symptoms. And if you look at the clinical indicators of failure according to the AHA and BCC guidelines, and those include heart failure hospitalization, need for INT support, persistent debilitating for symptoms, poor functional capacity as measured by cardiopulmonary exercise testing, intolerance to RAS inhibitors, etc. And you can go over the list by yourself. So the co-op trial was not really designed for patients with advanced heart failure. So the registry, which is encouraging for some patients, but not so much. So another question I asked myself is, if you actually put the keyword, is it going to delay or harm the patient if they're going to go for a bad? So there's one study that only a few studies that looked at this in the literature, and what they found that for a clip before bad, your outcomes after having an antibiotic is much worse compared to if you did not have a tear and if you go straight for a bad. So the summary, so what should we do for it? I think teamwork is very important. I think what we need to work with our interventionists and general cardiologists. And this is a suggested approach. We say the patient with advanced heart failure symptoms. If they're a transplant candidate, they should go for heart transplantation. Or they should go for a VAD. However, they're not eligible for a transplant. You can consider, if they're not eligible for VAD, you can consider TEER as a bridge to cardiac transplantation. And the patient for VAD, he should not offer TEER. And I'll conclude here. Thank you so much.
Thank you.